Hi, I'm Carey Jackson. I am a physician at Harborview Medical Center in Seattle, and from Harborview we operate an entity called Northwest Health and Human Rights, which is a partnership between the International Counseling and Community Services, Mental Health and Community Services Office of Lutheran Community Services, and the Northwest Immigrant Rights Program, which is a group of lawyers who are specialized in immigration law. And the three entities together have formed a Center for the Survivors of Torture that we call Northwest Health and Human Rights, we being the medical branch of the operation. And I work in this setting with Drs. Nicole Ehrenholtz and Dr. Mari Heider, and together we provide evaluations for asylees for asylum as well as evaluations of survivors of torture. Typically, we start talks like this with a case, and today I'm going to be talking about the sequelae of traumatic brain injury, and specifically memory difficulties as a result of torture. And this case that I'm about to play for you illustrates a typical episode of torture and blows to the head on the part of a gentleman who was seeking asylum from Gambia, 32-year-old torture survivor, who tells his story now. Describe for him, if you can, how you were hit and beaten. How did that happen?
I was like lying down on the ground and they were hitting me.
How many men?
8 of them.
Mm-hmm.
Some of them were kicking me, and others are using their UK gun, the handle on my ribs and kick me everywhere on my head. But I was doing like this all the time to protect my ribs and my head. But even though that couldn't help though, so that's where I get all these bruises, you know.
Okay.
And I have one here in my neck because they point something very sharp. After that I feel something like a blood. So now it's me that used to make it like this, but it's something that happened during the scene.
There.
Yeah. And my head, anytime I hold it, sometimes I have a very bad headache. It's like something is inside my head, been hit so hard, and the pain is like, the pain don't want to go away. So, and my legs too, I have some.
How did these happen?
This happened because where I was lying down, there was a stone. So by the time they were kicking me, I was moving my legs, so the stone was like kind of sharp, just cut my leg.
Okay. Now, the thing that I want you to pay attention to with his presentation is a couple of things that we'll return to. One is his affect and the very subdued and complaints that he has of chronic headache and memory disturbance, as well as the way that the injury occurred. Traumatic brain injury has become of general interest in the United States, I think, because of several popular occurrences. One has been the prevalence of Parkinsonism and dementia among boxers, and similarly the prevalence of chronic degenerative neurologic states among professional football players, and then concerns that even high school and middle school and younger participants in sports may be sustaining traumatic brain injuries that will affect them long term. And so for that reason, and as well as military reasons, with the returning veterans from Iraq, there's a growing interest and awareness and a plethora of research in the area of traumatic brain injury. So that among statistics that are maintained by the CDC, it's estimated that about 1.7 million traumatic brain injuries occur on average in the period of time between 2000 and 2006. And while this is clearly an underreporting, because there are many, many mild cases that don't go above threshold to be counted, this estimate resulted in about 1,365,000 ER visits and 275,000 hospitalizations. 43% of those resulted in long-term disability, and among these numbers included 52,000 deaths. So the mechanisms of traumatic brain injury are familiar to physicians. There are essentially four general types of mechanism. One is the impact that one would get during a beating or in a motor vehicle accident, which often results in vascular hemorrhage, and traumatic axonal injury, which we'll return to. The second is inertial loading, and I'll give you examples of that from rapid movement of the head forward and backward. The third is a penetrating wound from a bullet or shrapnel, which causes local tissue necrosis, and finally a blast, which is a wave of pressure differential, which can result in brain swelling. Here's an example from the military that shows the various mechanisms and how they operate on a GI who's undergone an IED. He experiences a blast or a wave of energy and pressure difference that moves through his brain, causing the swelling, followed by a piece of shrapnel that penetrates his brain, causing local tissue necrosis, and then the impact of inertial loading, and then finally hitting his head on that rock, which causes the coup contra coup lesions that we always think of with traumatic as a mechanism of traumatic brain injury. The military, in reporting how common traumatic brain injury is in the military, either pre or post-war, when they did a surveillance between 1997 and 2006, found remarkably that the impact of war had relatively little change in the statistics. It did what you would expect if you look at the slide, and you see that, of course, battle raises the percentages from 0.3 to 7.2%, and so does weapon injury go from 0.6% to 5.5%, as you would expect in battle, or a time of war rather. And you see a commensurate drop in injuries from athletics, as you would expect. But the injury rate from falls, from assault, self-inflicted, and from other causes are remarkably stable. The Institute of Medicine made an attempt to assess the long-term health effects of traumatic brain injury by severity, and categorizes it into three general categories. One, mild, where there's very little evidence of any kind of association for causality and or even physical associations because of the underreporting and the understudy, essentially. Moderate there's a fairly strong evidence of causality for seizures, unprovoked seizures, and some association with growth hormone insufficiency, Alzheimer's, endocrine dysfunction, Parkinson's, adverse social function, and premature mortality. Severe, on the other hand, is also associated with neurocognitive deficits as listed above, including dementia and other chronic neurologic conditions, as well as unprovoked seizures. In the case of torture, it's the traumatic brain injury from coup contra coup, from beatings, most often the case, rifle butts, and blows from objects like this baton or from fists that are most often reported and that result in the coup contra coup activity. Here's an example of coup contra coup where you can see that initially both the inertial loading in the case of a motor vehicle accident or in the case of a blow to the head results in contusions in the occipital area and also in the frontal area after there's a forward movement and backward movement. This also sometimes affects, as you can see, the anterior-most portion of the temporal lobe. What happens in the setting of coup contra coup and these frontal lobe contusions is the impairment of frontal executive function by and large. So this means that attention, memory, language association and language ability, and motor behaviors that are initiated there for the mediation of real-world problems are all affected. And since traumatic brain injury has a predilection for the anterior portion of the brain, as I pointed out, with both polar and ventral frontal regions being particularly prone to contusion and damage, it's this area that's most often affected. And because in the frontal lobe the neurons there have such long axons, it's this diffuse axonal injury that's observed throughout the neuroaxis, but it's more concentrated in these anterior regions because of the length of those axons. If you look at the neuroanatomy of the brain and were to review what executive functions are located in the anterior portion or in the frontal cortex, there you find planning and problem solving, short-term memory, speech formation, a little bit more temporal and lateral, as well as voluntary movement. More occipital, you find balance and vision, and visual data gets analyzed, as well as sensory data analysis. So those are the areas most commonly affected with coup contre coup contusions. As you saw in that first case that I presented, one of the issues is that you have two events happening simultaneously. You have injury to the brain from a beating or from torture, and you then also have a traumatic event which results in post-traumatic stress disease. I think for most primary care doctors, we're much more comfortable and conversant with PTSD, especially in the setting of caring for survivors of torture. So we're much more likely to diagnose PTSD and treat it and feel comfortable treating it, right? So you hear about the flashbacks, or you see that they're avoidant, hypervigilant, that they report nightmares, and they often re-experience the phenomena. They also might complain of fatigue and insomnia, very sad affect, and being irritable and anxious. And it fits the criteria for PTSD and typically results in an SSRI or narrative exposure therapy or other approach to managing the symptoms. But the fact is that some of those symptoms overlap with traumatic brain injury, the fatigue, insomnia, depression, irritability, and anxiety specifically. But with traumatic brain injury, you're more likely to experience headaches and dizziness, as we pointed out from the neuroanatomy, nausea and vomiting, vision problems, sensitivity to light and noise, other cognitive changes like irritability, as we mentioned, impulse control, and memory disturbance. So, as I was pointing out in the neuroanatomy, that this frontal region is responsible for multiple executive functions, and these are varied and integrated and involved in complex ways for solving everyday problems. So, for example, the dorsolateral prefrontal cortex is responsible for spatial, temporal, and conceptual reasoning. Superior medial prefrontal cortex is where initiating and maintaining mental processes and monitoring response conflict occur, sort of regulation functions. The ventromedial prefrontal cortex is the location responsible for behavioral self-regulation, like emotional processing, overriding impulses, the mediation of stimulus-reward associations. And then finally, the frontal polar regions are responsible for metacognitive processes, that insight that we have towards our capacity for tracking our personality, our self-awareness, our social cognition, how we're performing socially, and prospective memory, as well as other complex multitasks. And these are the areas most likely to be involved in a direct blow to the front of the head. It's when this kind of injury occurs that we see language impairments. With frontal cortex injury, we'll find language impairment, sort of classic aphasia syndromes that we see often in strokes, for example, anomic aphasia and Wernicke's aphasia, that kind of fluent aphasia that we can assess. But there are also subclinical aphasias, and this is often the case in mild to moderate traumatic brain injury, where you have processing deficits that are subtle but detectable. Object naming, verbal associative fluency, the comprehension of complex commands, and maybe they're comprehended, they're just processed slowly, or taking writing from dictation or to dictation. You also see pragmatic use of language affected, so there's less productive, less efficient speech, more fragmentation, sort of stilting, halting speech, and difficulty sometimes initiating speech or maintaining a topic of conversation. Distractibility is part of this. Hard to follow or track a listener and respond and interpret more subtle kinds of communication that are indirect or implied. And then there are even more frank, sort of gross speech disorders such as mutism or stuttering, echolalia, or dysarthria. It's apparent that we're going to have neurologic deficits in the case of severe PTSD, severe brain injury, traumatic brain injury. That's going to result in ER visits as a rule or death in the field. Moderate is, I think, the gray zone that we end up often evaluating. And we're often wondering what to do with a history of traumatic brain injury that apparently was mild, but we're not sure how it might have left our patient impaired. And it's useful to have a definition of traumatic brain injury, and the Institute of Medicine provides this definition. It's a mild traumatic brain injury is a physiologic disruption of brain function as a result of external force that is indicated by the new onset of at least one of a specified set of clinical signs immediately following or shortly after the event. And these are, number 1, alteration of mental status, number 2, loss of consciousness, number 3, focal neurologic deficit, but where the severity of injury does not exceed post-traumatic amnesia for greater than 24 hours. Number 4, a Glasgow Coma Scale, that's between 13 and 15, 30 minutes after the event. And number 5, a loss of consciousness that does not exceed 30 minutes. If it meets that criteria, it's a mild traumatic brain injury. If it's longer than that, then it's moderate or to severe traumatic brain injury. Now, clearly, these are criteria that have to be assessed shortly following the traumatic brain injury. That can happen at the side of a football field or in a boxing setting or sports setting, or maybe even in battle, but rarely happens for our patients, virtually impossible when they are in a warfare situation or when they are imprisoned and tortured. The symptoms of traumatic brain injury that might be long-lasting that people would report who've undergone this, who've endured this, include cognitive changes, which is what I'd like to focus on for the rest of the talk, but also can include headache, sleep disturbances and fatigue, dizziness, imbalance, vestibular dysfunction, vision problems, chronic pain, sexual dysfunction. As we saw before, there's a strong association with unprovoked epilepsy or seizures. Impulse control and aggression is not an infrequent consequence of traumatic brain injury. And also subtle findings. People will say that ever since he endured that or she endured that event, their personality has changed. They're just a little different. Other mood disorders that go along with PTSD that we discussed earlier, as well as the frank psychosis in severe cases where people begin to have difficulty tracking reality, hallucinations, and severe cognitive impairment. Listen to this woman's story as she describes her experience of torture and the injury she experienced and that she endured to her head.
When they beat you, did they knock you out? Did they hit you in the head and knock you unconscious?
Yes. They beat you and with the rear of the gun they will hit you on your head. Yes, I collapsed, yes.
Do you know if you were unconscious for a long period of time?
Yeah.
What about broken bones in your head, your jaw, your body? Did they break you?
Well,
oh, I'm so sorry. What about burning you or shocking you or boiling water? Did they do any of that to you?
No, they did not.
Did they cut you at all or no? What about now? Do you continue to have headaches or memory problems or hearing problems?
Yes, I have
headaches or jaw pain?
Whenever they hit me, always.
How about your vision since those days?
Eji amanta laki jira ko dure chuga na nyati male foniga daina te fo ambra te mbe kuna nyati jigaru
that you can see.
dawana akabani sa
لكن نلالتا أركون وركتاي.
arkuni na kagaru ijata na gawa wa ambra te bo aske sa watu na jira yero takataka jirgata na nimana tudita.
How about seizures? Did you ever have a seizure in there when you were?
Ketewa matumahana ni yero dur kaunda de nyerosa matumahana ni yero du or kaunda de nyerosa ni kizabana dera le matan kuna mana dise male matumahana.
So, as you see in that story, she is most aware of the fact that her memory has not quite been the same. It may be that her personality changes and some of those metacognitive processes are affected, but she's not aware of that. She is aware of the fact that she can't remember like she used to. Accompanying that often diminished motivation, awareness deficits, and other symptoms, as I noted before. So, how to get at what might have happened? What kinds of questions are productive for a clinician to ask? So, some of these sample questions for traumatic brain injury assessment include those in red here, which try to characterize the event. Have you ever hit your head? Have you ever been in an accident? Have you ever been in or near an explosion? Have you ever been mistreated by the military or the police? And did you suffer any other injuries if that's the case? And then these questions in green try to get out how severe this might have been, whether or not people were unconscious for greater than 30 minutes. What's the last thing you remember? And what's the first thing you recall? How long were you unconscious? Did anyone witness or observe this and report it to you? And that's just to try to tease out, was this mild, moderate, severe? And then finally, what are the long-term consequences of this? Has anyone told you that you've been different since the injury? How is your memory? And finally, many people who have injured their heads drink or use drugs to help them. Do you? And these are useful questions, fairly succinct, that can be used in a screening process as you're taking a history from somebody who's endured warfare or from an area of the world where torture is highly prevalent and considered by many just routine events in day-to-day life. So as I said, during the rest of the talk, I'd like to zero in a little bit on memory, because that's often the hardest thing to help people with. We're more accustomed to managing memory issues in the setting of dementia. And while traumatic brain injury can lead to dementia, what's happening with traumatic brain injury is slightly different. But it's useful for those of us that are in medicine to think a little bit about the types of memory that we try to assess and track for the sake of being able to ask fairly pointed questions about memory. So I'm going to do a little review of kinds of memory here to help you with some insight around taking a history of memory. Anterograde memory, you know, is the ability to learn new information. So anterograde amnesia is the deficit of conscious, deliberate recall or information first learned after the brain insult. Retrograde memory, on the other hand, is the retrieval of information already learned. Declarative memory is specific personal experiences and biographical events. So that would be the things that happen to one, not facts about the world or things that you've learned. And then finally, semantic memory. That's the memory for concepts and the knowledge of objects that are stored in language and memory. So there are other types of memory that sort of intersect with this and overlap these. One is procedural memory. That's perceptual and motor skills learning. And so that would be like skating or opening a can. You could have an individual who had a large CVA and can't speak, or maybe has impaired hearing, but you hand them and they have very little anterograde memory, but you could hand them a can and they'd very efficiently open it because they have that sort of perceptual and motor skills memory intact. Then there's the priming memory, the enhancement of test performance as a result of previous exposure to a context or to material. There's also the classic conditioning of Pavlov, you know, the stimulus and the response that are paired after conditioning. And then there's the types of memory involved in executive function, which we've been talking about. Working memory, the temporary storage and manipulation of information. Strategic memory, the application of active organizing and elaborative strategies. Source memory, the context in which a memory is formed, remembering where and when, the order and recent proximity of the event. This kind of memory is often perturbed in the setting of torture or head injury of any kind, even a motor vehicle accident, where people will find the sequence of events jumbled for them. They can't remember the context and the order of events. This is particularly difficult for people seeking asylum because the Immigration Service will call them out on this and use it as a pretext for dismissing their case or returning them to the country of origin, when in fact it's a normal sequelae of traumatic brain injury for somebody who's been tortured. Then there's prospective memory, which is that memory to remember to perform a function in the future, like take a medication or make a call or keep an appointment. And this kind of memory is often perturbed in the setting of traumatic brain injury. And then finally, meta-memory, which we often see affected among dementia patients, which is sort of insight into one's memory abilities. For assessing these things, we are often dependent upon very simple screening tools, especially in primary care and in medicine in general, where we are not neuropsych evaluators, and we're trying to assess memory as well as liver function and diabetes and high blood pressure and depression. We have to be as efficient as possible. And the tools that we're given, for example, the Montreal Cognitive Assessment, are somewhat culturally biased, obviously, so that if you're not familiar with Western numbers and letters, you would have a hard time using this particular document. You'd have to mock up something similar. If you're not familiar with clocks, although most people are, but many people now, my own kids, are more familiar with digital timekeeping, you would have a hard time drawing the face of a clock. And these are animals that are familiar to zoo-goers. If you grew up in the highlands of Burma, you may not be familiar with a hippo or with a giraffe and have a hard time coming up with a word in your language for it. So this is a culturally sort of biased form, and at the same time it may be the best that you've got to work with and is modifiable. I would encourage you to try to use it, because at least many people can work with this, and at least you can make an attempt to establish a baseline. Now, there are other easier evaluations in some ways than the MOCA, or at least to augment the MOCA because of its sort of cultural biases and its limitations. And these are simpler in some ways. We talked about clock drawing. That's still somewhat culturally biased, although I think a lot of people are familiar with timepieces like that. The other one's verbal fluency. Now, you may have to work with an interpreter here, but list the number of animals in 1 minute, or list the number of words that begin with the same letter. You can come up with some culturally appropriate equivalent. Failure is less than 10 items. So, for example, the first case that we saw, I asked him he was an English speaker, and I asked him to name all the words he knew that started with B. And I heard him using language, and he mentioned all kinds of B words in the course of normal speech, but when he was asked to retrieve words that began with B, he couldn't do more than 4. Other things include set shifts and sequencing. So on the MOCA you saw that pattern of 1A, 2B, 3C, 4D, kind of as it should be. So failure would be the failure to assign the right pairs of letters and numbers. Another thing that's easy to do as part of your neurological examination is the fist palm side sequencing, where you stick your fist in your right fist in your left palm, and then your palm to palm, and then the side of your right hand to your left palm, and rapidly alternate these movements, and then ask the person to do the same thing. And they typically can't follow the rapid alterations and keep the sequence right and perseverate on one movement. And then finally, asking a person to say 2 when you hold up one finger, and then 1 when you hold up 2 fingers, is sort of the opposite association, and that their inability to inhibit the visual stimulus and say the same thing, 2 when they see 2 fingers, is a failure. And these are sort of quick evaluations of frontal lobe function at the bedside. So, what then are our treatment options? And I think this is where we're going to go next, because there's not great evidence for effective therapy, and yet the physician is left wondering how they can help somebody who has had a traumatic brain injury, who is really distressed by their memory. what evidence there is for treatment comes from multiple sources, because with traumatic brain injury, as we've seen with boxers and professional athletes, there are symptoms of and the eventual development of dementia. There's also Parkinsonism, a certain amount of distractibility, as you see in ADHD, a certain amount of depressed arousal, as you might see with narcolepsy. So the initial therapies came from these other chronic conditions and were tried in the setting of traumatic brain injury. The therapies really come down to a handful, most notably cholinergic agents and CateCholAminergic agents. There are some that have been studied more intently than others. For example, physostigmine is very toxic, and so clearly not a testable entity for cholinergic agent. And cytidine 5'-diphosphylcholine, you can't even find that. So that leaves us with the cholinesterase inhibitors, notably Aricept or donepezil, and rivastigmine and galantamine. Most of the clinical trials have been done with donepezil or Aricept. There are also CateCholAminergic agents that we'll look at, like methylphenidate or dextroamphetamine, amantadine, bromocriptine, levodopa, and selagelene, which is experimental, that you might have some, that there might be a few reports on. In terms of studies that actually look for evidence of improvement, they are really limited, and the evidence is mixed. So cortical acetylcholine, plays a role, obviously, in attention, memory, and executive function, as we've seen in the case of Alzheimer's, and why procholinergic agents are the mainstay of treatment in Alzheimer's. So there have been a few studies that have looked at Aricept or donepezil in the setting of traumatic brain injury, and these vary in their methods and efficacy. Mori, for example, in 2003, took a look at 10 milligrams of donepezil for 6 months, then did a 6-week washout, and then another 6 months at 5 milligrams a day, and found in his setting significant impact on visual memory, but no other significant improvements. Walker, in the next year, 2004, and colleagues, had negative results when they took people with severe traumatic brain injury and conducted a retrospective design of a little over a month post-injury, and then initiated 34 days of treatment. A few reached the actual 10 milligram threshold of treatment, and their instrument was insensitive to the drug impact, so there was no real positive results. So one other study by Zhang et al. In 2004 took 18 patients with both moderate and severe traumatic brain injury, 4 to 5 months post-injury, and they used 2 measures of memory, both verbal and nonverbal, and these were 2 sub-tests on the Wechsler memory scale. And they randomly assigned people to donepezil or to placebo, and they found significant improvement in favor of donepezil on all measures: immediate memory, distractibility or attention, processing speed, but they did not look at any functional significance in day-to-day life. Nevertheless, there have been at least a couple of studies that show that donepezil improved memory for traumatic brain injury patients, and I'd like to make the distinction with Alzheimer's, where we typically give donepezil and don't expect people to have improved memory. We just hope that it slows the rate of memory deterioration. But in this case, they actually were able to measure, and you should be able to see clinically, improvement in memory, and so it makes it possible to track improvement if you have a baseline, as we previously discussed, in terms of your assessment with a MOCA or some other measure of memory. So then what's the role of psychostimulants? There have been a few studies that looked at methylphenidate. So Kim et al. In 2006 took 20 milligrams of methylphenidate and gave it to chronic TBI patients that had mild cognitive impairment, and they found enhanced speed and accuracy of memory both 2 and 48 hours post-dosing. White in 2004 studied 18 cases. Most of these had chronic severe traumatic brain injury that had chronic impairment, and found that methylphenidate improved processing speed, but not their distractibility, and the improvement was not particularly profound. And then finally, Wilmot and Ponsford in 2009 had a randomized controlled trial that with a crossover early in the recovery period from moderate to severe TBI, and found enhanced information processing speed but no impact on complex tasks, and bigger effect size were seen in more severe cases. Other CateCholAminergic medications that have been studied include dextroamphetamine, but there's only one case and not particularly good evidence. Amantadine, drawing from the Parkinson's literature, used in the setting of traumatic brain injury, where there's decreased arousal and behavioral disturbance, showed both improved attention and speed of processing. Krauss gave 400 milligrams daily to 40 patients with varying severity of TBI for 12 weeks. And pre- and post-neuropsych testing, as well as PET scanning, showed improved executive function, but not attention or memory. And there was a concomitant increase in glucose metabolism in those areas of the prefrontal cortex where you would expect it to overlap to account for the changes in memory. There are two other studies that had contradictory results with amantadine, so the jury remains to be out on amantadine. Powell and colleagues looked at levodopa. They found some improvements in mutism, but not in attention or memory. White, 2008, using levodopa with moderate to severe TBI in the post-acute recovery phase, 6 weeks after the event, then given medication for 6 weeks, double-blind, and then placebo-controlled, using bromocriptine 5 milligrams BID. The patients did worse than placebo on measures of attention and distraction. But blood pressure also dropped, so the trial was completely discontinued. So in this case, bromocriptine was contraindicated. Lai et al. In 2008 took 12 severe TBI patients and showed improvement in arousal, attention, and initiation using bromocriptine. And finally, Krauss and Maki in 1997 showed improvement in cognition when levodopa was combined with amantadine. How about the role of antidepressants in medication in the setting of traumatic brain injury? Tricyclics were investigated by Reinhardt in 1996 and Robelsky again in 1993, and both showed improvements in arousal and in initiation in their trials. In contrast, SSRIs show no improvement in memory or cognition. In fact, it makes it worse, and even normal subjects will show decrements in working memory with SSRIs. So where SSRIs might be useful for depression and improve PTSD symptoms, they actually will not help with memory if that's the primary complaint. Depression, on the other hand, is life-threatening, where people get suicidal, and so it makes most sense, it seems to me, to treat PTSD initially and worry about traumatic brain injury once the depression is stabilized. And so there may be strong reason to give SSRIs for other reasons and deal with traumatic brain injury later on as one switches over medications after the patient's stabilized. Finally, Lee in 2005 compared methylphenidate directly to sertraline in the setting of mild and moderate traumatic brain injury and showed improvements in depression for both groups, but in cognition only with methylphenidate, which supports what we've seen earlier in these trials. In summary, mild traumatic brain injury is very common in war and torture survivors and has many sequelae. Nobody will report it to you. People are often ashamed of the fact that they've been tortured or want to forget it and are humiliated by the whole experience. So to find out about it, you have to directly go looking for it. They will not bring it up spontaneously. In fact, they may try to obscure it. And then once you find that it's memory that's been affected, you need to sort of establish some baseline of their cognitive ability. So that will mean asking questions that tease apart what aspect of memory is affected. Is it your antegrade memory? Is it retrograde memory? Is it your memory for events? Is it your memory for names? Is it the speed with which you remember things? Figure out what exactly it is and establish a baseline there. Family members and friends may be essential for this because you don't know the patient and you won't be available to tease out where their memory is most affected. They may have issues of metacognition, so they may not have any insight into how their memory exactly is affected. They just know it's not good. And so you may need a family member or a friend to help you characterize where the memory deficits are so that you can establish a baseline. And finally, consider an intervention. Admittedly, the data is not great. It's very sparse and sketchy. The risks are minimal, though. And it's not the same kind of risk that one would see in dementia. If donepezil doesn't work, you can safely stop it. So one could try donepezil or amantadine. In some cases where the cardiovascular risks are not huge, you might even try methylphenidate and see if there's any impact on baseline measures of memory that you've established.